Okay, this is the screencast for Chapter 9. We're now on to joints. We're going to classify joints a couple different ways. We're going to classify them by how they move, which is here, and then we're going to give them structural classifications. So one of the things you're going to want to do, I think the best way to organize the joints in terms of studying them is to organize them in your mind by their structural classifications, and then make sure you keep track as you're going through each individual joint what its functional classification is. So as this says here, synarthrosis just means not movable, amphiarthrosis means slightly movable, and diarthrosis means freely movable. Then we are going to have these three different structural classifications, and this is the framework that we're going to put all the individual joints into. So you're going to have three different kinds of fibrous joints, two different kinds of cartilaginous joints, and 6 different kinds of synovial joints. So we will start with the fibrous joints. We said they are going to be 3 different kinds. They are sutures, syndesmoses, and gomphoses. What they all have in common is that they're joined together by dense fibrous connective tissue. So this is dense regular connective tissue that's being used to knit or join 2 bones together, and they do not have a joint cavity or synovial cavity. Your cartilaginous joints will be the same way. They will not have a cavity. So your first fibrous joint is a suture. Sutures are synarthrotic, and it's just short, dense, regular connective tissue fibers that hold together the bones in your skull. So sutures are found in your skull and only your skull. As it says here, somewhere about middle age, the bones fully ossify. So one bone actually grows right into another, and you no longer have what would be called a suture, but you can still see what's left over from where the suture was. Then your next fibrous joint is called a syndesmosis. This is when 2 bones are held together either by a short ligament or ligaments, like you have here in the in the distal fibular radial joint, or tibiofibular joint. I said fibular radial. Your ankle is not connected to your wrist. This joint right here, tibiofibular, your tibia, which is your shin connected to your outer leg bone by these 2 short posterior and anterior inferior ligaments. But there are also interosseous ligaments like this one here in between your tibia and your fibula, which hold them together. So this is the interosseous membrane between your radius and your ulna, and technically it counts as a syndesmosis. There's also a synovial joint down here and up here, so the connections between some of your bones is sometimes more complicated than just one joint. But we are referring to this interosseous membrane as a syndesmosis between these 2 bones, and it does allow for a fair amount of movement. When you turn your wrist over, it is the end of your radius rotating over the end of your ulna, and some movement happens because, or is allowed to happen by the interosseous membrane there. So those are amphiarthrotic syndesmosis. The suture was synarthrotic. Gomphoses are also synarthrotic. Apparently I spelled it wrong. Did I spell it differently here? Oh, no, I guess it's just not in the word bank for PowerPoint. So the asynarthrotic joint is the joint between your teeth and what is called the margin of your jaw, or the sockets for all of your teeth, and it's kind of like a suture. It is a very short ligament that knits the tooth into your upper and lower jaw. And they are supposed to be synarthrotic until they degrade and your teeth fall out, but then they're no longer doing what they're supposed to do, so they are considered synarthrotic. Then we said we were going to have two kinds of cartilaginous joints. What they have in common is that it is cartilage that is joining the two bones together, and they also do not have a joint cavity or synovial cavity. And the two different joints are going to be typified by different kinds of cartilage. So first up is your synchondrosis. This is when two bones are held together by hyaline cartilage. And because hyaline cartilage is inflexible, these are referred to as synarthrotic joints. So technically speaking, the connection between the epiphysis and the diaphysis of all of your growing long bones qualifies as a synchondrosis, because the epiphysis is a separate bony structure attached to the diaphysis by your epiphyseal plate cartilage, and there's no movement there. And then also rib number 1 is directly glued to your sternum by a little bit of hyaline cartilage, so that is also a synarthrotic joint. Oddly enough, right, all of your other ribs do have some fibrocartilage between them and the sternum, but they actually qualify as synovial joints because there's a little bit of movement and there's a synovial membrane. So there's actually a series of plane joints that lets the ribs slide back and forth against the sternum as your rib cage goes up and down. So it's just rib number 1 that is glued directly to your sternum. Then the second cartilaginous joint is a symphysis. This is typified by fibrocartilage. This is an amphiarthrosis. There's a little bit of movement. And we have two examples of them where they're basically the same kind of joint. It's a symphysis joint. You have the intervertebral disc, which we've seen between your two vertebrae, and then the pubic symphysis, which is that pad of fibrocartilage right there between your two pubic bones. So this part of your pelvis and that part of your pelvis are called your pubic bones, and they meet right there in the middle. So this is absorbing a lot of the shock that gets transferred into your pelvic brim or into your pelvis by your femur, so all the forces coming up from your leg. Then there are the synovial joints. There are going to be 6 of them. Before we talk about them individually, we need to know the 6 different anatomical properties that all of your synovial joints have in common, even those plane joints I was talking about between the ribs and the sternum. One is that the ends of the bones are all coated in articular cartilage or hyaline cartilage, so that's this blue layer here. They are all defined by having a joint capsule. So the outer part is the capsule. That capsule is going to be lined by a synovial membrane, and that is then going to define the synovial cavity. So this space right here. So the capsule, then the cavity, which is filled with synovial fluid, which is very slippery. So right then what you have in one of these joints is 2 bones coated by, remember, tough shiny plastic. Hyaline cartilage is like the outside of a football helmet. So you have 2 football helmets rubbing up against each other with some lubricating fluid in between them. There's not going to be a lot of friction there. So these joints are supposed to operate smoothly and also not wear down the bones in them, because the cartilage can be replaced as the joint wears. Then also all of your synovial joints have reinforcing ligaments and a rich nerve and blood vessel supply. That is not shown here, but you just want to imagine that there's a ligament that goes from here down to here and maybe one on the other side. Right, this right here does not look like a very stable joint. These 2 round structures would just want to slide right past each other. Usually your joints have a little bit more of a stable arrangement than this. And then the rich nerve and blood supply also is not there, but you just want to imagine lots of nerves and blood vessels. That's where the synovial fluid comes from, is blood vessels that supply the synovial membrane, and then cells in the synovial membrane secrete the synovial fluid. In addition, some of your joints have bursa and tendon sheaths. We first start with bursa, and these are a little bit hard to see because we don't have the greatest images in the world, but it is basically a sac, like a little ball bearing, filled with synovial fluid. So imagine, like a little bubble of membrane filled with synovial fluid, and what they do is act like ball bearings. So as two parts of a joint move, if there's a bursa in between them, instead of a tendon rubbing up against a ligament or a tendon rubbing up against a bone, there's a bursa in between those two structures that rolls back and forth and reduces the friction between those moving structures. Then there's also a tendon sheath, which is the same concept as a bursa. It is a sealed sac of synovial fluid with synovial membrane around it, only it is elongated and wraps around a tendon. This is the tendon of the long head of your biceps that runs up over the top of the head of your humerus and attaches to just above the glenoid cavity here, just above your shoulder socket. So as you move your shoulder around in the socket, this would be rubbing up against the tendon. And tendons are dense regular connective tissue. They're not meant to take a lot of friction, and they don't grow back easily, so they need to be protected from friction, and that's what your tendon sheaths do. Then, before we get into the individual joints, we want to know what it is about synovial joints that keeps them stable or keeps them from becoming dislocated or misaligned. And they are listed in order of their importance. So one is the shape of the articular surface. So if we just go back and look here, right, this is a ball and socket joint. You do have a round head on the humerus and something of a depression in your shoulder scapula, so that keeps the head from slipping out of the shoulder socket. But this is not a very deep pocket at all. And if you look, say, at your knee, right, this is a little convex and this is a little concave. So there is a groove for your femur to fit in on top of your tibia, but it's not really deep. It doesn't lend a lot of stability. So there has to be other anatomical features that keep your knee or your shoulder or all of your other joints from becoming dislocated. So this is where ligaments come in. They help keep your joints properly aligned. But the most important factor in stabilizing your synovial joints is something called muscle tone. So when I say muscle tone, it is a very specific thing. It is not going to the gym and getting a little bit of definition. It is a neurological phenomenon called tone, whereby your nervous system is constantly stimulating your muscles at a low rate or a low level. Basically, in each muscle you have hundreds or thousands of different muscle fibers, and at any given point in time, maybe 2 to 5% of them are contracting, keeping a certain amount of tension on all of your muscles. And then the muscle fibers take turns contracting, so your muscle never fatigues, even though it's always generating a little bit of tension. And because you always have, they're not shown here, muscles that cross joints, because that's how you get joints to move, that muscle tension is what keeps your joints properly aligned. So you want to know this, and most importantly, you want to know that muscle tone is the most important factor for keeping your joints aligned. And this is why when people do sprain or strain joints, the physical therapy for it is always strengthening the muscles that support that joint. So next up is different kinds of movement. And this, I have to say, is going to be hard for me to teach online. I usually am in front of a classroom doing this. So non-axial, as it says right there, is gliding or sliding movements. Basically, like if you take your hands and make like you're going to clap and then rub them together, that's gliding. Some of your joints do that. The best example I could give you that you could do at home yourself is if you protrude your jaw forward, like you're going to make an underbite, and then pull it back, or if you slide your lower jaw back and forth, that's your mandible, your lower jaw, just gliding forward and back or left and right in the mandibular fossa that it articulates with. Uniaxial movement is easy enough to describe. That's how your elbow works, right? You can change the angle, this is angular movement, between two bones along one plane of movement or one axis of movement. So that's how a door works, or the hood for your car. Biaxial angular movement, this is movement in two planes. Not super common. The place where you're going to see this is the joint between your fingers and your first knuckle. So not the second two where you're bending your finger, but where your finger moves relative to your palm. You can bend your finger forward and back to make a fist or open it up, but you can also wag your fingers back and forth a little bit. So that's biaxial angular movement. Multi-axial angular movement is what your shoulders and your hips are capable of. Right? So if your leg is straight, then the angle between your femur and your vertebral column is 180 degrees. Right? It's straight down like that. You can move you can move your femur out to the side, up to the front, out to the back, right? There's basically any plane of movement is open to the femur for angular movement, and the same thing with your shoulder. You can bring it forward, you can bring it back, you can bring it out to the side. You can change the angle between your humerus and your scapula, excuse me, I'm pointing to the clavicle there, through many different planes. And then circumduction is moving in a circle. So that's just taking all of the angles and putting them together. And then rotation, again, this is like what your skull does, is just rotate. You're not changing any angles, you're just changing the position of your head relative to your neck in a rotational fashion. So then what we're going to do is go through, now we're on this slide already, these different kinds of joints, and for each one you want to know the shape. So we're going to describe the shape of the joint, what kind of movement is allowed, and an example. All right, so if you were making flashcards, you might write plain joint on one side of the flashcard, and then on the back of it you might say flat articular surfaces allows for gliding or non-axial movement, and this is the intercarpal and intertarsal joints. So you have a whole bunch of bones in, if we go back here, your ankle and your wrist that are just small little nuggets with relatively flat surfaces where they meet, and they just sort of jostle around and slide back and forth next to each other, not creating a lot of movement but just kind of shuffling. Those are plain joints, plus the joint between, well, we'll get to that. The one I was talking about for your lower jaw, your mandible gliding back and forth, is not necessarily a plane. It's like a modified hinge. Speaking of hinge joints, right, so these are hard to describe, so I didn't put a description in there, but it's basically a tubular convex bone that fits into a tubular concave condyle. So it's like two rounded condyles that come together. Hinge joints allow for uniaxial angular motion, which in lab we're going to call flexion and extension, but don't worry about that right now. And these are the joints that form in your elbow, your knee, and the joints between your finger bones, or the phalanges. So this is not the joint between your finger and your palm. I don't have a good close-up to show you what I'm talking about, but it's the joint between the bones that make up your finger. So those two joints beyond your big knuckle where you can bend your fingers. Those are all hinge joints. Next up is the pivot joint. Here you have a round head of some sort that will fit into a sleeve. This sleeve is usually a ligament, some dense regular connective tissue that is just holding one bone next to another while the rotating bone rotates in that sleeve. So this is for rotation only. It is typified by the proximal radial ulnar joint, which again I don't have a good picture of. I thought I brought a picture of that in here. Let me go back real quick. Here. So this joint right here. This is where your thumb would be. This would be somebody's right hand. The palm would be here. The thumb would be there. If they turn their hand over, the thumb ends up over here, and this part of the radius pivots over the top of the ulna, and you get pivoting down here as well. So the head of the radius swivels in a little ligament that holds it up against the side of the ulna when you turn your hand over. That's pronation and supination. And then the other one that is sort of typified here is the joint between C1 and C2 that you saw last week, where the dens is the thing that pivots in this little ligament that holds it up against the anterior arch of the atlas. Next up are condyloid or ellipsoidal joints. These are where both of the articular surfaces, the convex and the concave surface, are oval in shape. This allows for biaxial angular movement. So if this part here is wider here than it is that way, you can move along those two planes, but you can't twist it all because it's an oblong shape. So again, condyloid joints, oval in shape, allow for biaxial angular movement, and these are the joints between your finger phalangeal bone and your palm metacarpal bone. So the phalangeal metacarpal junction. And one of these days I should just get better images. Then you have saddle joints. This is a weird joint. As far as I know, there's only one true saddle joint in the body. It allows for biaxial angular movement and circumduction. If you think about the way a saddle works, it has both concave and convex areas. Right, so if you look at a saddle from the side, where's saddle? There it went. If you look at a saddle from the side, it looks like that. If you look at a saddle from the front, it looks like that. So you've got the concave surface, the convex surface that your legs roll over, and then the convex surface that you're kind of sitting in with the horn of the saddle there, and then the back of the saddle, and we'll put some tassels on it. We'll make it a very fancy saddle. Sorry, I'm getting carried away. But you can see, depending on how you look at the saddle, it's either convex or concave. And you can think about the way that saddle works. You can't really twist in it, but you could fall to either side, your left or your right, or you can lean forward and lean back. So you've got angular movement along this surface or angular movement along that surface. That's what you get between the the metacarpal bone in your thumb. So the bone in your palm that supports your thumb, which then attaches to your carpals or your wrist. So this isn't the base of your thumb. This is where the palm of your thumb meets your wrist, and you can get biaxial angular rotation and circumduction there. It's almost like a universal joint or a CV joint in a car. If anybody's ever looked at like their drivetrain, the way the drivetrain is hooked up to the rear axle, it's kind of like that. Or at least it used to be. I don't know if it still is, because they've changed a lot of things. Let's see, then we get to ball and socket joints. This is the easiest one. So you have a round head that fits into a round socket, and this allows for everything. So multi-axial angular movement, that includes circumduction plus rotation. So this is the only joint that gives you both angular movement and rotation. So it is the most freely movable of all of your synovial joints, and it's your shoulder and your hip, or your glenohumeral joint and your hip. If you are looking for a way to organize all of this, you might want to try making an outline. Now, this is not going to include the kinds of movement and the 6 structural features that all synovial joints have in common, but it might not be a bad idea to make an outline like this to remind you how all of the joints are organized, and then fill in everything that we just went over. So fill in the details on ball and socket joint. Where did I put it? Here, right? So you would go and say round, moves a lot, whatever. If I were you, that's how I would organize this information, and then go back through and rewrite all of this in outline form. It would be a really good way to study if you're trying to commit everything to memory. Let's see, we have just a few slides left. We're 27 minutes into this. Let's just keep chugging along. Common joint injuries. A sprain is technically a ligament stretch. If it's a really bad strain, it can be torn. Generally, these are difficult to recover from if it's a good strain, because ligaments are not meant to be stretched. They're not elastic, so when you do stretch them, they generally don't return to their original length. And then once a ligament becomes longer, you've lost some of the stability on that joint. Now the bones can move around a little bit more, and the more they move, the less stable the joint becomes. And this is why, if you've ever sprained an ankle, you are prone to spraining it again because you've weakened it, and you have to do a lot of work strengthening all of the muscles that support that joint. Cartilage tears are just that, cartilage tears. Those are also hard to recover from because cartilage does not repair itself very well. If you get bursitis or tendinitis, both of them are basically the same thing. They're either overuse injuries, or they might be caused by degeneration of a joint. Either way, they cause pain. You get a little bit of stiffness because your brain doesn't want to use that joint because it's getting this pain feedback from it. And then you have to take some sort of anti-inflammatory and painkiller like ibuprofen or Aleve. And then if it gets really bad, you take anti-inflammatory steroids like cortisone, excuse me. Let's see, arthritis. Arthritis sucks because it's painful and you get stiffness and swelling in your joints. We are going to go over 3 different types of arthritis: osteoarthritis, rheumatoid arthritis, and gout. First up is osteoarthritis. This is, as it says here, the most common form of arthritis. It is a degenerative disease, so it is not something that generally gets better. You can slow it down, and this happens when your cartilage stops replacing itself. So it doesn't necessarily happen just because you've used up all the cartilage. It happens if you are prone to having your cartilage stop replacing itself, then you develop osteoarthritis. So if you are not predisposed to this, let's say that your cartilage just keeps on replacing itself and you're a marathon runner, you can run marathons when you're 30, when you're 40, when you're 50, 60, 70, it doesn't matter. As long as your cartilage keeps replacing itself, you can keep running. Some people, their cartilage is different. It stops replacing itself. So whenever their cartilage stops replacing itself, that's when they have to stop running. But it is not the running that is causing the arthritis. It is simply making the arthritis more noticeable earlier. So if you're a runner and you develop arthritis in your knees or your hips, you are probably going to become aware of it relatively early in the progression of the disease because you're using those joints a lot and putting a lot of stress on them. If you are a more sedentary person, or maybe you swim and cycle and you're developing arthritis, you may not know it. Your cartilage is getting thinner and thinner and your joint cavity is getting smaller, but because you're doing low impact exercise, you may not be aware of your arthritis. So running high impact exercise doesn't cause arthritis, it just makes you aware of it. If you do keep doing the things that make your arthritis hurt, then you can accelerate things. But run all you want until you start to feel pain, and then you have to slow down. This is just an example of a knee with osteoarthritis and a healthy knee. So here's the healthy knee. This black space in between the femur and the tibia, that's cartilage. It's filled with cartilage, those two bones, or the synovial cartilage of those two bones is touching. It just doesn't show up in the x-ray. Here, especially on the inside, you can see this knee has collapsed on itself. There is almost no space in between the two joints. So you've got pretty much bone on bone here. And the other thing you can notice, if you look over here, you have this nice sharp line here. And then over here, especially there, the line is kind of blurry. And you can see some, looks like a little something squirting out beside there. Those are bone spurs, and that happens once you start getting bone-on-bone rubbing in a joint. That puts stress on the bones. Bones grow in response to stress. So once you start overusing an arthritic joint, you get these bone spurs, and that just accelerates the process and reduces the range of motion that you have in that joint. I will say, if you do have arthritis, it is to your benefit to keep moving, because the more you move a joint, it encourages the production of synovial fluid and will help you maintain the cartilage that you still have. You just don't want to do anything that hurts. What's next? Rheumatoid arthritis. There used to be more information on this, but we don't have time to cover everything. This, you want to know, is an autoimmune disease. It is chronic. It is now much more treatable than it used to be. It just depends on the severity of it. And this is when your immune system attacks, I believe it's the synovial membrane, some part of the joint. The immune system treats as though it were a virus or a bacteria, and you get inflammation and swelling in the joint, and that causes pain and stiffness. Then osteoarthritis is when you get uric acid crystals deposited in the synovial fluid of the joint, and then that irritates the soft tissues like the synovial membrane around it and causes inflammation and pain. Why it tends to affect the joint at the base of your big toe, I do not know, but that is what it is associated with. It used to be thought of as a rich man's disease because a lot of the uric acid comes from DNA, some of the bases in the DNA. And if you think about different foods, right? Fruits, vegetables, especially starchy foods, tend to be cheaper than meats, and they're also not as cellular dense, right? If you look at like a potato, the cells are really big because they're filled with starch. So anytime you're eating a vegetable, you're getting fewer cells per serving because of all the starch and fiber in fruits and vegetables, whereas meat is completely cellular. So you're getting many more nuclei, you're eating a lot more DNA when you eat meat. And meat is generally more expensive than vegetables, which is why gout was typically associated with wealth, because poor people couldn't afford enough meat to make their gout worse. That is it. That's the whole chapter in 35 minutes. Thanks for hanging out this long.